Welcome. At this time, all participants are on a listen-only mode for the duration of today's conference. If you would ask a question during the conference, please use the Q&A box on the WebEx presentation or send an email to the addresses provided in the slides. This is being recorded. If you have any objections, please disconnect at this time. I would now like to turn the call over to your host, Subrato Banerjee. You may begin.
Hello, everyone. My name is Subrato Banerjee. I'm with the Department of Health and Human Services, Residing office in San Francisco, California. We thank you for your interest in wanting to learn more about ACA enrollment and outreach to help citizens from the 3 COFA nations obtain health care coverage in the United States. Our agenda is packed with presentations from colleagues around the nation who are extremely committed to working toward collaborative solutions for this complicated issue. Neil Cox will provide an overview of the geopolitical relationship which connects the 3 Pacific Island nations with the United States. Finally, Ian John will present a legislative update on Medicaid restoration for COFA citizens. And then Gardner will help clarify the opportunities for coverage on ACA for COFA citizens. Presenters are health professionals from the great states of Hawaii, Utah, Arizona, and Arkansas. These will share their respective state efforts for outreach to COFA communities, offering real boots-on-the-ground feedback, lessons learned, and recommendations for other states embarking on similar outreach efforts. This panel, my colleague Kathy Wassam will provide our closing and summary remarks. I wanted to read the comments Victor made at the beginning regarding questions. We're going to the chat box and to obtain your questions. Please, if you have questions during the webinar, please use that chat box, select me or the host, and we will be monitoring those questions along with my colleague Bonnie Preston from the Regional Director's Office. We urge all of you to send questions during the webinar and after the webinar to the email address on the screen. With that, over to our first presenter, Neil Fox. Thank you.
I'm providing a geopolitical framework for health and migration of the people from the freely associated states of Micronesia. What we're talking about is 3 areas: the geopolitical relationships, the history, about the treaties or the compacts of free association with 3 countries, and then what happens in education outcomes and particular perceptions and issues of trust in that particular geopolitical environment. Lastly, I'll be speaking about migration. What has occurred since migration? Migrants have come to the United States and the acculturation process has taken place, and why is that relevant to the migrants' health and literacy? Slide, please. So the United States affiliated Pacific is made up of territory, Guam and American Samoa, and Commonwealth of Northern Marianas, but it's also made up of 3 independent countries called that freely associated states, and we'll talk more about that. They are the Federated States of Micronesia, the Republic of the Marshall Islands, and the Republic of Palau. Next slide, please. And so this middle of these areas, the target middle is the Republic of the Marshall Islands. The horizontal oval next to that is made up of the 4 states of Pohnpei, Yap, and Krushrai, which together they make the Federated States of Micronesia. And to the left of that, that small oval is the Republic of Palau. And so you know, because the primary groups that we're talking about today will be all 3 nations, but it'll be largely centered on the Marshall Islands and the Federated States of Micronesia. Next slide, please. So these 3 countries, the Republic of Palau, the Marshall Islands, and the Federated States of Micronesia, were under really colonial rule, like a lot of the Pacific, for 400 years. First Spain, then it was Germany, and then Japan at the end of World War II. At the end of World War II in 1946, these areas came under United Nations trusteeship. The United States then requested and obtained administrative oversight of Northern Marianas, Palau, Chuk, Yak, Kusrai, Pohnpei, and the Marshall Islands. Together, these areas became known as Trust Territory of the Pacific Islands. And consequently, it was branded as the Strategic Trust of the United States because strategic was used because it was taken on as for military reasons. Next slide, please. So, states in 1946, and in the territory of the Pacific Islands, set a military base in the Marshall Islands, and that base is still there. It's one of the Centers for the Strategic Defense Initiative, and it's currently named Ronald Reagan Missile Range. And they also began their U.S. nuclear weapons testing in the Marshall Islands in 1946. The primary objective of the trusteeship for these areas was economic development and reliance. Next, please. So, nuclear testing began, and it continued for 12 years. In that 12 years, the megatonnage was equivalent to 7,200 Hiroshima bombs, and so the detonation was above the ground. So, one of the things about this area, and especially the Marshall Islands, is a nuclear legacy. Next slide, please. In 1960, the United Nations said to the states, you're not really preparing Micronesia, the area that you took under your TTPI, you're not preparing them for self-government, and that's the objective of doing this. So the United States began pouring in a lot of resources after 1960 in health and education and so forth. And then, in line with the United Nations mandate in 1977, the United States offered political self-determination to all these areas, which include the Northern Marianas, Palau, Lines, Chuk, Yap, Kusrai, and Pohnpei. And then what happened was the Northern Marianas in the United States, we want to become a U.S. Commonwealth, is what occurred. The Marshall Islands and Palau said, we will become independent. They did so under what's called free association with the United States. I'll talk about that a little bit more. And then the remaining areas, Chuk, Yap, Kusrai, and Pohnpei, came together, although they have different language and different cultures, and became the Federated States of Micronesia. And together that became an independent nation, which also linked to the United States in a free association. Next slide. Free association. The free association means that each of the countries, Federal Micronesia, Republic of the Marshall Islands, and the Republic of Palau, are independent nations. They're sovereign nations. And FSM, our treaty began in 1986, and the Republic of the Palau began in 1994. The treaty is called, they each have independent treaties. So they're not one compact, there's three. And each of the nations has their own respective compacts called COFA, COFA, Compact of Free Association. And in these compacts, there's provisions. There's a military provision, there's an economic provision, and there's political provisions. The military provision is called strategic denial, and what that means is the military has complete oversight of all these areas. So the United States has complete military say over these areas. And the quid pro quo for that was they give these areas economic assistance in the form of grants and other economic assistance. And notably for the FSM and the RMI, these provisions will end in 2023. Then political provisions is what and why this conversation is a political provision where these folks can work, live, and reside in the United States without visa or green card in perpetuity, meaning that even when economic provisions end, this provision goes on forever. There is no end to it as written in this treaty. And therefore, these folks are not immigrants, and that is an important point. They're called migrants because they can work, live and reside and go back and forth without a green card. So terminology, they are migrants, not immigrants. Next slide, please. Objectives of these countries was predominantly from the view of their countries themselves, was to advance economic development and self-sufficiency. The United States Government Accountability Office, the GAO, assessed this, objective in 2003 and said the goal has not been achieved for the first 15 years. So since 1986, for the first 15 years, the goal wasn't achieved of economic development and self-sufficiency. And the US GAO said in the second compact, the second 15 years, which will end in 2023, economic self-sufficiency is not likely to occur. So the objective from the country's standpoint has not been met. Next, please. So shortages, and this is a picture of Ebi Island, and the economic shortage. There's 10,000 people that live on 66 acres. They work on the military base. But my point is, in this slide, is that sometimes there's not even enough water in the infrastructure, so they have to go to the military base to get water. Next slide, please. And so that of per capita expenditure in health, you can see the United States at the bottom, and then all the U.S. Associated Pacific areas at the top. And you can see what's the Marshall Islands, $414, $240. This is a comparison slide just to show you the United States resources if they spend in the continent, the United States, versus what happens in the territories and the freely associated states. So they look at disparity. Next slide, please. So health incomes in the political framework. So if you look at infant mortality, in the United States, infant mortality is 6 per 1,000 live births. And if you look at the FSM and the RMI, which is the Marshall Islands, it's almost fourfold that of the United States. Longevity, how long people live. In the United States, on average, it's about 79 years old. FSM in the Marshall Islands, it's a full 10 years less than the longevity in the United States. Next slide, please. Health parameters in the United States, in general, the adult population, diabetes is about 8%, and the states of Micronesia and the Marshall Islands, 30 to 37%. So again, 4 to almost fivefold that of the United States. Hepatitis B barrier rate, which is a determination of liver cancer and cirrhosis, is about 15 to 18%. In the United States, it's 2%. Cervical cancer, highest incidence in the world in Marshall Islands. Obesity rates, are in the top 10 worldwide. And the important point about the health, the statistics, and the infrastructure in these areas, specifically in Marshall Islands and in the states of Micronesia, is not robust. In fact, for the people listening, in the first states of Micronesia, there's actually no mammogram for cancer screening for breast cancer. Next slide, please. Education and economy is important in the health dialogue. Is the children who finish high school, public high school in the FM in the Marshall Islands, when they finish public high school, they read and do math on about the 5th grade level. The GDP per capita is about $57,000, and the unemployment rate in the United States is about 8%. As a comparison, in the Federal States of Micronesia, the GDP, gross domestic product per capita, is about $3,000, and unemployment rate is 22%, and the RI unemployment is 33%, and GDP is $3,600. So again, a comparison of the countries and what's happening in these countries currently. For migration to Hawaii, of course, this was studied, and because of the geopolitical relationship that I explained to you, they're coming here for health, education, employment, and job opportunity. Next slide, please. So where are they going? They're going to all 50 United States, and look at this slide later. Next slide, please. This slide's a little bit old, but it shows portion, and right now it's actually about 50,000. And actually, number 2 is Arkansas, which is about 9,000. But this slide goes a little bit dated. It shows the main states where a lot of the compact, the free association folks are migrating to. Next slide. And population growth by ethnicity. This one is important because it shows you that in the United States, that look at the first line, the Chuukese population between 2000 and 2010, growing at an enormous rate. Migration is high, 144%. If you go down a little bit, Marshallese, 237%, Polynesians, 194%. This is compared to the other Pacific Islanders. So the point, great migration rates. Next slide, please. And cyclical disease among COFA migrants in Hawaii and elsewhere. So one of the reasons for presenting what their health status was in their own countries is because their health status moves with them when they migrate to the United States. And so all the diabetes rates and cancer rates and so forth that I showed, it moves with them as they migrate. But also, tuberculosis and Hansen's disease, the statistics from Hawaii moves with them. So 94% of the new Hansen's disease cases, which is leprosy in the old terminology, were from actually the freely associated states. Now, one of the things that I want to frame this in is health literacy. So in dialogue today, the notion of health literacy is extremely important. Health literacy of an individual is really the ability of an individual to receive, understand, process, and use health information. This is important because it allows an individual to successfully navigate the healthcare system. Therefore, the migrants' ability to use language, their level of education, their cultural alignment, values, and their financial resources is extremely important. Next slide, please. Look at the limited English proficiency of the population of Marshallese. It's 41%. So again, in a health literacy context, you're looking at Marshallese that have 41% of limited English proficiency. It's even greater than the Latino population, Asian American population. Next, please. Their achievement as far as bachelor's degrees, Marshallese 1%. So again, that is to give you a context of their education and their eligibility and what that does for their health literacy. Next slide, please. And equality, their financial resources. Marshallese low income in the bottom line, so there's 2 lines there. The lighter line is those in poverty, and the one above that is those that are low income. And so compared to other groups in the Pacific Islands, but also the Latino population and Hawaiians, you can see the poverty and low income is extremely high. So in comparison, again, this is context for their health literacy and ability to get through, the health system matrix in the United States. Next slide, please. So, the general reaction is, this is from Hawaii, is that the people migrating from these areas cost the United States and Hawaii a lot of money, and the free associated people are at fault for what's happening to them in the United States, either their low literacy, their high rates of lack of finding themselves in the homeless and poverty levels, and they are at fault for that that situation, and their individual responsibilities are lacking. They overuse the health system, they overuse educational resources, they use the system from minor reasons. They're not participating in their own health care, and the blogs, the news, and sentiment in Hawaii is extremely negative towards this population. And the perception of the freely associated states, the people from there, is that wait a minute, we were colonized. You did your testing on us. The infrastructure development that you promised didn't occur. And even the issues around climate change, which are affecting the way they live, affecting them so that it drives the migration. And there's a lot of trust issues and issues about attributing who the responsibility is for their condition. And so the U.S. people's perceptions about the migrants, as well as the migrants' perceptions about the United States, like any other relationship, must be taken into consideration during the acculturation process. The perceptions are founded in understanding history, and I just wanted to, that as the last slide. Next slide, Ian, and Leon, it's over to you.
Thank you very much, Neil. Thank you for that information. My name is Ian John. I'm a policy director with the Asian Pacific Islander American Health Forum, a national nonprofit health advocacy organization, and we really focus on improving the health of Asian Americans, Native Hawaiians, and Pacific Islanders. And I'm going to talk a little bit about some of the legislative efforts gone on to ensure that COFA citizens have access to care. As Neil mentioned, health outcomes and indicators, the high incidence of cancer, there's a real need for healthcare access in the U.S. And you mentioned poverty and low income. And so to that, I'm going to speak about Medicaid coverage, because as part of the treaty in 1986, COFA citizens were initially eligible for Medicaid, SNAP, other federal means tested programs, and all fell under the definition as qualified aliens and were under coverage for that since 1986. That happened 10 years later in 1996, under the Welfare Reform Act that went into effect. The designations were changed at that time as debate was going on, and as people looking at what categories of people should be covered. The designation changed to non-qualified aliens, and when that happened, then the citizens were moved into the non-qualified alien category, and as a result, they lost coverage under Medicaid. And so that's big, something that had a real impact on healthcare access and coverage for COFA citizens. Now all states have the option to provide CHIP coverage for lawfully present women and children who would otherwise be subject to a 5-year waiting period. And some of the states have really taken up the option because of the federal Medicaid. We left out of federal Medicaid coverage. So the coverage for COFA migrants is limited, however, as only a few of the states with large COFA migrant populations, Neil mentioned some of those states, Arkansas, California, Oregon, Washington. A few states do provide care to pregnant women and children regardless of their immigration status. So I'm going to go to the next slide, please. I'm going to some of the bills that have been introduced to try to restore this coverage, the Medicaid coverage for COFA citizens. Since 2001, 21 bills have been introduced to correct this exclusion. And I'm going to talk about several different pieces of legislation. So the first is the HEAL Act, or the Health Equity and Access Under the Law for Immigrant Women and Families. This is a bill that was just introduced in April of this last year, April of 2015. I'm Representative Luan Grisham from New Mexico. And basically what this bill does is that it restores full scope Medicaid and Children's Health Insurance Program, or CHIP coverage, for all lawfully present individuals who are otherwise eligible. It removes any discriminatory legal barriers to health coverage for lawfully present individuals that was imposed by the 1996 welfare law. It eliminates really these categories of qualified and non-qualified immigrants or migrants. So anyone who's here lawfully present would be covered under Medicaid and CHIP, which applies to COFA citizens. So it takes a kind of a broad approach to making sure that a lot of different categories of lawfully present individuals have coverage. So this particular piece of legislation was introduced earlier this year. It has broad support. It has 43 co-sponsors, including Representative Mark Takai and Tulsi Gabbard of Hawaii. Next slide. So two specific bills that have been introduced, and bills really have been introduced, they were introduced this last year, but over the last 10 years or so, several bills have been introduced by different Congress members to try to really restore Medicaid coverage for COFA citizens. These two bills have been introduced in May earlier this year, and this is really focused on the Welfare Reform Act itself and amending the specific language there that removed COFA citizens from coverage. So both these bills, Senator Hirono introduced Senate 1301, and Representative Gabbard introduced the House version of this bill. Both of these bills are focused on amending the language and are specific to creating a Medicaid eligibility exception for COFA citizens. For the Senate bill, there's Senator Schatz of Hawaii is the co-sponsor, and for the House version of the bill, there's co-sponsors Representative Takai from Hawaii, Representative Bordala of Guam, and Representative Grio Sublan from the Northern Mariana Islands. They're all co-sponsors on this bill. And again, these two bills really focus on specifically amending the Welfare Reform Act and making sure that COFA citizens are eligible under Medicaid. Finally, I want to talk a little bit about another initiative that was part of comprehensive immigration reform. So if you remember back in 2013 when the whole debate was going on about comprehensive immigration reform, one of the most promising efforts to kind of get back was through the introduction of this bill by Senator Schumer, and if you remember the Gang of Eight, as they were called at the time. So Senate Bill 744, known as the Border Security, Economic Opportunity, and Immigration Modernization Act, or immigration reform. There were many amendments that were introduced to that bill, and one of them was introduced by Senator Hirono, was to specifically, as the Medicaid restoration bills have to do, was to create this Medicaid eligibility exception from the welfare reform and to include co-citizens under Medicaid coverage again. So that amendment was introduced by Senator Hirono. It passed by voice vote in the Judiciary Committee, and it was included as part of the Senate bill as in one of the sections. But as you know, the whole immigration reform kind of into a heated struggle and battle, and that just completely died. So that's one of the most promising efforts to get coverage was through the immigration reform effort. In addition to what's happened in the past, I will say that the Health Equity and Accountability Act, this is a piece of legislation that is very broad in addressing health equity. It's been introduced over the last couple of years. Every Congress it's introduced, and the next Congress will be introduced in 2016 by Representative Robin Kelly. I'm not sure exactly when that would be introduced, but probably early 2016. So the Health Equity and Accountability Act also includes more broad provisions to include health care coverage for a large number of lawfully present individuals, including COFA migrants. So that's something, again, to look ahead to. Just wanted to kind of give a sense of what type of bills have been introduced. You know, it's hard to say really what's going to happen with all of these bills because things have been introduced in the past. It really depends on the climate, the political climate. But that's just a kind of a sense of where we've been and what's to come in terms of legislation. So now I'll turn it over to Ken.
Thanks. So given that we're going to try and talk just a little bit about the many options that are available for COFA migrants. Medicaid, as Ian talked about, is somewhat limited. We'll talk a little more about that. The health insurance marketplace is created under the Affordable Care Act. Medicare and options like community health clinic, federally qualified clinics. So, as pointed out, the situation on COFA citizens and Medicaid, COFA citizens are not considered qualified immigrants for federal Medicaid eligible services. And federal Medicaid funds can be used. But some states, for example, California and Hawaii, have provided Medicaid or other limited coverage to COFA citizens using the state funds. It's also true that the children and pregnant women may be eligible under CHIP, the Children's Health Insurance Program, if the state chose to cover lawfully present residents in CHIP or expansion. And some states did that. And just to add to the confusion, many people that are covered under CHIP got it in Medicaid, and so the concepts are easily confused. The bottom line is, Medicaid isn't available to COFA citizens in most states. Ask about your state situation. So, insurance marketplaces created under the federal or the Affordable Care Act. There are several types. There's the federally Facilitated Marketplace, or FFM, which one most people know about as the health insurance marketplace, either by our websites, healthcare.gov, or nationcuidado.salud.gov. But there's also a variety of types of state-based marketplaces. And I'll get into the differences, types, but just to give a few examples, there's California, there's Well in New Mexico, there's Connect in Kentucky, there's Nevada Health Link, many different options. Certainly I haven't covered them all here. Look for these marketplaces. But eligibility is the same whether you're in a federal or a state-based model. You have to live in the United States. And if you do live in the United States, it's important to understand that services are available when you're outside the U.S. So a lot of work in Arizona. If you live and work in Arizona, you happen to cross the border for a day, a week, or a month, you're covered when you're in Mexico. That's the concept. You all have to be either a U.S. citizen or national, or be lawfully present in the U.S., and that includes green card visa holders, refugees, asylum, etc. And you can't be currently incarcerated. If you are in jail or prison, it's expected that the prison system, for example, will cover your health care. Who's not eligible for the marketplace, just the other side of the coin, undocumented immigrants. So this is the dreamers, the folks under DACA. Also, anyone with Medicare, Medicaid, or an offer of employer coverage. Basically, if you've got insurance somewhere else, you're really eligible for the health insurance marketplace. Exception to that, if your employer coverage is unaffordable, and we define that as it's being over 9.56% of your income for self-only coverage, that is only for the employee, if that's over 9.5% of the household income. It's a little bit of a difficult bar to meet. So are COFA citizens eligible for the marketplace? It's a big resounding yes. COFA citizens are considered lawfully present, and they're eligible to join so long as they reside within the 50 states. Now, places don't operate in the COFA countries, in Guam, or CNMI, the Commonwealth of Northern Marianas Islands. So if you reside there, you can join. I've been out the documentation that COFAs can use to join the marketplace. There are options. I can't go into all of them here, but the two most common are the Form 94 or the 766. Applying to the marketplace, what happens too, which confuses people, is you might be told that you're eligible for Medicaid. So this happens to you or someone that you're helping with an application. First to do is don't believe it. If you state that doesn't offer Medicaid coverage to COFA citizens, and you're a COFA citizen and it says you're eligible, just know that that's sort of part of the dance. You got to go through this. You do is apply for Medicaid in your state and get denial. And go back to the marketplace and use that Medicaid denial to qualify for marketplace coverage. If you've done this even once since 2013, that denial still qualifies you to come to marketplace. And I'm going to show you this in an actual marketplace application in just a moment. Big to remember too, just a concept, there are appeals available. It's sort of a complicated system. So if you receive a decision from the marketplace that you don't agree with, you can appeal it. So maybe you submitted your lawful presence documents, but they weren't accepted. Or you get Medicaid denial, and your income's low enough to get tax credits, but for some reason you're not getting them, or a problem like that. There's a cost to appeal the decision, and it will put your case in front of a hearing officer, carefully review the evidence, and can correct the problem if a mistake was made. They can't change the rules, but they can make sure the rules were properly followed. So if you file an appeal, but it's best to do it through something like a navigator in your area so that you can make sure that you really filled out the application properly. Because when it really boils down to it, these appeals occur because someone filled out an application and answered a question wrong. Often these things can be fixed without going to appeal, but those appeals are always available. So the big question really is financial assistance for COFA citizens. What's really available? So in the marketplace, there are two kinds of financial assistance. The first is a tax credit, advanced premium tax credit, or APTC. These people pay their premiums if their income is less than 400% of the federal poverty level. Also, COFA citizens have access to credits and income even more than they normally would. If their income is in the range they would normally qualify for Medicaid, they can still get tax credits. We'll show you more about that. One kind of financial assistance are known. It's called cost sharing reduction. This helps you with the premium, but it does lower your out-of-pocket costs, your co-payments, deductibles, that sort of thing. To get that, you have to enroll in a silver level plan and available if your income is below 250% of the federal poverty level. And I'll give you an example to help you understand that. So I promise you don't have to do any math here, but I had to throw in one formula here just to help people understand the concepts. So the tax credit is based on a benchmark premium, the second least expensive plan in your area for someone of your age or your face size. And benchmark premium minus the expected contribution, the amount the ACA expects you to pay as the maximum for your insurance, is what you get for the tax credit. See, what you pay is limited by your income. And this is a chart you probably won't see anywhere else. And you don't have to memorize this, but I just wanted to sort of hone the concept. So people, as you go down this chart, if people get higher on the federal poverty level, you can see in the third column there, they pay a percentage of their household income. That's the maximum they're expected to pay for their health insurance, and see a monthly amount in the right-hand column. So highlighted in yellow is for people income less than 133% of the federal poverty level. For the populace, they're going to be eligible for Medicaid if they're in a Medicaid expansion state, but for citizens, recent immigrants, etc., they are by law not eligible for Medicaid. So tax credits are extended to them at lower incomes, which means their contribution, if their income is less than 33% of the federal poverty level, it maxes out at about $26 a month. So that's pretty. Summarize that, COFA who are not eligible for Medicaid can join the marketplace for as little as 2% of their household income if their income is in that Medicaid range, if they otherwise would have qualified for Medicaid. The point I've got to get in here is if you receive credits, APTC, you have to file a tax return, even if your income is so low you would normally have filed. So we're working with someone that perhaps applied and got a tax credit in 2014, but they haven't filed their tax returns. They're not a tax credit in 2016. Mm-hmm. They have to go ahead and file that return now, even if it's late, in order to reconcile the advance credit with the tax credits, which is the actual income for the year. The second way of making coverage more affordable is the cost sharing reduction. If your income is below 250% of the federal poverty limit, this lowers the out-of-pocket costs. And it's not real well understood. No need to memorize these numbers, but this is an example from one plan in California. And you can sort of see across the top, the standard social plan covers 70% of expenses on average. But there are tiers for people with income below 250%. So let's jump over to that right-hand column. The over 94% plan pay on average 94% of the cost for services rendered. If your income is for the person below $17,235, that's 150% of the federal poverty level. So you need to look at all this chart, but if you look at the second highlighted in yellow, the primary care visits, you can see standard plan, you'd pay $45 out of pocket to go see your primary care doctor. But for the person way on the right-hand side of the chart, they pay $3. Similarly, if you go up to the other highlighted section here, the deductible goes from $2,000 for an individual, $4,000 for a family, to $0. There's no deductible for folks in this particular income group. So just understand that these cost sharing reductions, depending on how low the person or the family's income is, it really cuts their out-of-pocket costs. So just briefly to Medicaid, I want to stress that Medicaid is run jointly between the federal government and the states. So if you've seen one state's Medicaid program, you've really only seen one state's Medicaid program. Some states have other options, both Medicaid or outside of Medicaid. For example, is pretty generous. They pay the premium after tax credits are applied for citizens or other lawful permanent residents who are eligible for the marketplace and income below 100% of the federal poverty level. Hawaii also uses state funds to send Medicaid services to COFA citizens and other LPRs who are aged, blind, or disabled. And like Hawaii provides services to COFA children and pregnant women through a CHIPRA expansion. There's a lot of information there, but again, the key is tying up the situation in your state. California also uses state funds to extend Cal or Medicaid coverage to lawful permanent residents. This includes COFA citizens. If you have trouble applying to the marketplace, there is help available all across the country. If you go to healthcare.gov, search find local help, you'll get this page. You can put in your zip code, and it'll give you a list of people in your area that are qualified to help you through these applications. Now, I'd be remiss if I didn't mention that if you don't get coverage and you're eligible for it, there is a penalty. It's an individual mandate. That's what they've called it a lot in the press. If you don't have health insurance, you may very well be required to pay a fee. There are exemptions from this fee based on circumstances. For example, if your income is low to require you to file a tax return, you're exempt from the fee. And citizens residing in the U.S. are required to pay U.S. income taxes, so they are subject to this fee, unless they get an exemption. This is our infographic on it, which is a little hard to follow, but the bottom line is these started out pretty low when the program began in 2014. It was $85 per adult or $750 per child, or 1% of the household income. It's the larger of the two is what you pay. But they've gone up considerably. In 2015, that went up to $325 per adult or 2% of household income. And next year, it maxes out at $695 per adult or 2.5% of household income. So the idea how that really impacts folks. Look at, stereotypical family of four, really low income, $30,000 a year, 124% of the federal poverty limit. In red, you can see the penalty based on their family size. In yellow is calculated by income. They have to pay the larger of the two. So in 2014, they would have had to pay $285 in penalty for not having coverage. In 2018, this year, it's $975. That year, it's over $2,000. Now, that very same family has learned because their income is low, they're not qualified for Medicaid, they have to pay more than 2% of their household income to the silver plan. So that's $1,500 per year, and you can see in 2016, they buy a silver plan, the benchmark plan in their area, for considerably less than the penalty would be if you did have coverage. So pay attention to that. On grants that are available, companies are eligible for Medicare. Qualify for Medicare, you have to be 65 years old, or you have disabled according to the Social Security Administration. Medicare isn't free. If you worked in the U.S. for 40 quarters, as SSA says, or I say 2 years, and paid employment taxes, Medicare Part A is free. But if you haven't, you have to pay for it. It's $407 a month if you have no work history at all. It's a fraction of that if you have less than 40 quarters. And say you've worked 20 quarters in the U.S. and paid taxes, you'll about half that amount for Medicare Part A, which covers hospital services. Medicare Part B, everybody pays. This covers all outpatient services, doctor's visits, that sort of thing. This year, the premium is $104.90 a month. And for Part B, for drug coverage, the plan premiums vary. They're typically in the $20 to $50 a month range. varies widely depending on which one you choose and your local area. Medicare also has copays and deductibles. It's far more information than we want to put in a webinar like this. But you can go to Medicare.gov or visit your local SHIP office for more information. SHIP is the health insurance program. There are local offices in every county in the United States with trained counselors to help people figure out their best health care option in that local area. So they know about Medicare, they know about Medicaid, they know about any local programs and charities that might be available. Last, talk about community health clinics and qualified health centers. This is so often overlooked. If you can't afford any of this coverage, if you just don't have anything, anyone can go to a federally health qualified center and get service, primary care services as well as specialty services. Most of these exist to uninsured or the medically underserved. And there, as an example, there are 14 federally qualified health clinics in Hawaii. There are 18 in California. So check what's available in your area and go to findahealthcenter.hrsa.gov. Let me take very quickly through some selected screenshots from hypothetical COFA citizens applying on the marketplace, because lots of questions, people say, I went and I couldn't figure out how to do it. Well, this is for someone from COFA citizen. Start going through the application. I'm not going to show you the whole thing because it's too many screens, but you get a question, do you have eligible immigration status? So that arrow points says yes, you do. It's citizens of Micronesia, the Marshall Islands, and Palau are considered eligible immigration status for this purpose. And this is where you find this application. In this case, Kenneth Gardner answering the question, a U.S. citizen or U.S. national, and he said no, but check the box so he does have eligible immigration status because he is a citizen of the Marshall Islands. The next question is, what kind of document do you have to prove this? So look at that list. You're going to see, in this case, we're going to choose the I-94, the arrival or departure record. If you click that, it's going to ask you for a number. Gardner did not have a valid number, but he was still able to go forward with the application. And there are many other questions I sort of want to point out in red here. There's a question, do any of these people need help with activity of daily living? Well, this is several questions, and a navigator can point this up to you, that are in location to see if you qualify for Medicaid. If you answer yes to this, chances are the marketplace is going to think you're qualified for Medicaid. If you know that your state doesn't cover for citizens, then you might want to consider answering no to this question. But this yellow arrow there, were any of these folks not eligible for Medicaid or CHIP in the past 90 days? I clicked yes to Kenneth Gardner, yeah, in this case. That takes me to another page where it says, was this person found eligible because of their immigration status? Again, yes. So in this state, COFA citizens aren't eligible for Medicaid. To see you answer that question properly. Then it asks a series of questions about income. In this case, I put that Kenneth Gardner's income was $100 a month, so extrapolated that to $9,600 per year, which weighs below 100% of the federal poverty level. We put that in, and at the end you get what's called an eligibility notice. It's several pages. The key result is highlighted here. It said Kenneth Gardner, a COFA citizen with income below 100% of the poverty line, was eligible for a tax credit of $378 every month. We need more information. There's information because Kenneth Gardner wasn't able to provide the very numbers, immigration documents. And just very quickly, the benchmark plan for the rest used on that application was $395, and that tax credit met he would pay $17 a month, or could use that tax credit towards any other plan in the marketplace. So key points: citizens don't qualify for Medicaid funding, but qualify through CHIP. Some use state funding to extend Medicaid Medicaid. All COFA citizens are eligible for marketplace coverage. If they have Medicaid, and if they have a Medicaid denial, they get tax credits even though their income is very low, even zero, by the way. I checked that out. It does work. COFA citizens are subject to the tax penalties, but they're eligible for an exemption if they just can't afford the insurance. COFA citizens also are eligible for Medicare, reside in the U.S., territories, or CNMI. Medicare does operate in Guam and CNMI. But if they lack 40 work history, they'll have to pay more. And lastly, federal health centers and community clinics are always an option. There's always available local navigator, CHIP counselor, or clinic that can help you through this complicated process. Thank you much.
Everybody, this is Meredith. I'm with Hawaii Health Connector. I'm part of the Hi'iola program. I do that program, and Hi'iola is a Hawaiian word for embracing wellness. We, like I said, do all of the education and outreach in the community here in Hawaii, and we accomplish that mission through the incredible work of our in-person assisters. We call them kokua. Kokua in Hawaiian means helper or to help. Next. Thank you. So really briefly, and you've heard a little bit of this already from Dr. Palafox, but just to go over in brief our Hawaii situation. In November of last year, the state of Hawaii's Department of Human Services announced that it would be transitioning most of the citizens from the Federated States of Micronesia, the Republic of the Marshall Islands, and the Republic of Palau off of Medicaid. And when I say Medicaid, like Ken was talking about earlier, in the state of Hawaii, it was really a program that was a state-funded Medicaid-like benefit. So off of Medicaid and on to insurance through Hawaii's marketplace. The state does continue, as Ken reviewed, continue to provide Medicaid to youth, elders, those who are pregnant or disabled, but all others would see their Medicaid terminate on February 28th of 2015. The move impacted about 7,500 adults between the ages of 19 and 64 who are not recognized by the state as being disabled or pregnant. And the task for outreach really became, how are we going to meet with all of the members of this community to help them with this important transition? Next. So this is our outreach philosophy that we use here in the Hi'iola program. It's a quote from Dalai Lama, which is, you talk, you're only repeating what you already know. But if you listen, you may learn something new. And what we did was we took this philosophy and said, if we are to reach people from this community, our solution must be to somehow rearrange the budget to hire on individuals who have these language and community experience and skills to help serve the population. So we did just that. We immediately set out to hire 20 people from the community who speak Chuukese, Marshallese, Koshayan, and Pohnpeian. And we were also able to recruit some volunteers who speak Yapese and Palauan. And key to this factor is recognizing existing leadership from within the community you seek to serve. So who you'll see pictured here are some good friends of mine, Jojo Peter and Dina Sheck. Now, these people have been working as advocates in the community for long before this transition began. So as Hawaii was faced with this change of how to serve everybody, we immediately know you serve the community through the community and by working with existing leadership. And not just that leadership, but listening to and supporting those leaders and their ideas. As we know, linguistically and culturally appropriate communication is key and also an ACA requirement. You see pictured here are some of those language experts. I'm looking at this picture now. We have some Kosrayan speakers here, Pohnpeian, Marshallese, cheese. And you're also going to see an incredible woman named Josie Howard pictured there in the back in a white sweater. Josie Howard has partnered with an organization here called Partners in Development, and she has given birth to a new organization along with her partner Keola called We Are Oceania. But before any of that existed, this is a picture of an outreach where our kokua, all pictured in blue and one in orange, were there at St. Elizabeth's Church in Kalihi to serve the community, and Josie took upon herself and used all of her networking ability to help bring people to this event. Now, St. Elizabeth's is a known location, service provider location to this community, so it was a perfect place for us. Which leads me to what I wanted to really talk about was outreach success, I believe, is based on excellent partnering. Next. So partnering, you're going to see here in the picture some tents that Hawaii Health Connector put up in the park. We try to partner with everyone who's already working to serve this community. These photos will show you in Kaka'ako Park. There's a community leader named Catherine Xian who she's been serving the homeless community there for quite some time. And that homeless community includes many people from the nations under the Compact of Free Association. And because they've been living in this park, and because Catherine is a trusted person to that community, we were able to partner with Kathy and gave us access and introduction to these people, which allowed for us to work with them in a trusted way. Again, if we just popped up our tent without permission, without seeking that kind of partnering, we maybe wouldn't have had as excellent results. Next. And on partnering, this is a photo that was actually just taken about 2 weeks ago, kind of a pre-open enrollment, get the community ready meeting. And this was held at the Waipahu Health Fair. At the event, we saw hundreds of Marshallese, Chukis, Koshayan, Ponapean, and others. At this event, I want to really credit one of our community networkers here, Barbara Tom, and Waipahu Safe Haven, who really coordinated all the right players to be there. It demonstrates partnership between schools and students there, health students who were taking people's blood pressure, community health centers like our Kalihi Palama Clinic was there, public health nurses, our insurance companies, HMSA and Kaiser, were both present to explain their plans to people. Of course, you'll see in this picture our kokua, they're the ones who are madly looking at laptops and shuffling papers and answering questions. And a lot of service providers like legal aid, disability and recovery service folks, as well as government participation through the U.S. Center for Immigration Services. Next. And during this partnering, and I love these pictures because these are beautiful women, but I also want to point out that as I was taking this picture, there was a connection being made with this kokua above, who was working with one of the community leaders to solidify outreach plans for that November 1st, this past Sunday, open enrollment. And the outreach was happening at Chuki's Church in one of our public housing units, Quill Park Terrace, where a lot of people from that community live, resources, and in this case, attend that Chuki's Church. Next. So we'll talk about information sharing, which was what I've really been asked to do. Is one of the things that worked really well for us was regularly gathering all stakeholders. Weekly conference calls and weekly in-person meetings with stakeholders to share ideas, discuss what wasn't working, and as cheery as I may sound, not everything worked perfectly. And it was important to try to get decision makers in the room to advance ideas. I think the thing we really learned was to recognize the value of all perspectives in the room. You're going to have, whenever you're doing this kind of community work, the people who are policy and future focused. We had wonderful people who are focused on important aspects like the restoration of Medicaid, federally funded Medicaid, for the population. Cost share policies and funding to make sure there are no financial barriers to access, and movements on health literacy. And table, you'll also have people who are really focused on the immediate tactical needs. How are we reaching and enrolling the community? How are we ensuring enrollment is successful and people are connected with their health care? And what I would say is I believe it was a benefit to everyone around the table, even though everybody came from different perspectives, to hear what the other side was working on. It gives you confidence that this is being tackled from multiple points, and also makes you feel supported that the work you're doing is work that's understood across the table. Next. And more information sharing. What you're seeing here, and back to our outreach strategies, is a photo from one of our COCUA trainings. So remember, COCUA is the word we use for our in-person assisters. And it really is a train-the-trainers type of model, where we met with them for a full day to go through all that they will need to know. And of course, that's not true, right? Because we have weekly follow-up calls to continue the education because things change. We have 171 COCUA statewide who are doing this work. Among them, I'm really happy to say we have 60 COCUA who are bilingual, some are trilingual, and we now have support for 26 different languages through our COCUA. So our COCUA are extremely language rich, and that's really important when serving such a diverse community like we do here in Hawaii. Next. And so all of that learning, again, in the model of listen to the people who do the work, we created this binder of resources. And this binder idea actually came from a COCUA I was meeting with, and she made her own binder. And I thought, what a great idea. Let's get those for everybody. And so we did. Next. Sharing. What I wanted to bring up in these photos is I want you to pay attention to who's speaking. In the photo on the left, we have Yisa, one of our Marshallese COCUA, who is explaining to a group of Marshallese women in the Palau housing project all of the plans that they can enroll for. And then down below and to the right, you'll see an outreach that happened in one of our rural communities, Wahiwa, where a community television station was interviewing Linda Ricklin, who's speaking in Marshallese to the camera, and Sir Sonis, who's speaking in Chukis. And very important to us that these are the folks that are front and center providing messages in the community. We also have these wonderful young savvy COCUA who are taking to Facebook, Instagram, and other social media, creating opportunities for people to reach them, like the message in Marshallese that you're seeing here, and COCUA listing how they can be reached. Okay, so speaking of trying to simplify things, this chart it may look like the antithesis of simplification, but this one-pager really is the most frequently used tool in our community to help people understand the specific plans that leverage the best and most affordable coverage for them. So here in Hawaii, there are 6 such silver plans. It goes back to what Ken was saying about the silver 94% plans. And our COCUA take this in the community. It shows the 3 plans from Kaiser and the 3 from HMSA. So, I'll give you a little more zoomed in version so you can see it. This is what appears at the top left of the plan form, so you can see the name of the plan, what their person's co-insurance for ambulance would be, emergency room, hospital, inpatient, physician's office visit. Next. And the right-hand side of the sheet, which is the generic drug comparison, the brand name drugs, specialty drugs, not preferred brand name drugs, deductible, which for all the plans is 0, and then the maximum out of pocket. And then bottom of this plan sheet, and this is for our COCUA's use, it really is an attempt to help build that health insurance literacy, and after that, hopefully health literacy, by demystifying as much as possible some of the terms that we use so easily. Things like copay and coinsurance, if the COCUA has this in front of them to help remind them what it is, they more easily translate that for the community member that they're working with to try to help make these plans make sense to people. It really is a one-on-one kind of process. Next. So major lessons learned, things we sort of already knew, but that I would want to share with you folks is step back and support community leadership for the best outreach results. Location, you want to be where people are. You don't want to struggle to bring people to your event. You want to go to their events, their churches, and their meetings. You really communicate clearly and consistently, and then that last point is built right into that, which is possible. You want to minimize changes in information by clarity and accuracy over expediency. Sometimes we feel the pressure to move fast, but we want to make sure things are clear. To acknowledge a very important person in our community, Papa Mau, who's from the Sarawak Federated States of Micronesia and has since passed. Naina Thompson, our master navigator of the Hokulea, said about Papa Mau that he was the calmest presence in the fiercest storms. And this reminds me so much of the community we serve. This is by no means a weak community. The people that we serve are very calm and persevere, and they're very strong. Next. And to wrap, this is something we say in Hawaiian, A'ohe hanui ke aluia, which is, no task is too big when done together by all. Ma'a.
Hello everyone, greetings. My name is Jake Fitzsimano, calling in here from Salt Lake City, Utah, which is a place, and you may be wondering, why is Utah on this call talking about COFA migrants and communities? And we'll go over that actually, but the same kind of with the slides I have, which are very brief. We just want to share some of the ideas and some of the activities that we are doing here in the state of Utah. It may be a way that's a little bit unique in that Utah has a very large Pacific Islander population that's been here for quite a long time, 1873, which is only about 25 years after first European or white settlers arrived here in Utah. And so we do have very large proportions of Samoan community and Tongan communities here in the United States. When you compare cities and municipal areas, we actually have some of the largest populations compared to any other city here on the continent. The proverb that was there on the first slide, Fa'au Mataliaba, is a Samoan proverb, which is actually linked to that picture, which is of some navigators, some sailors from Sarawak. And really what the proverb talks about is tying canoes together in a way that they sail in the same direction. And so that's something that we've been doing here recently. Next slide, please. See that our collaboration, slide, please. Pacific Islander Health Coalition was founded in 2011. This is a group that has been very proactive, particularly in the Polynesian communities, that is Samoan, Tongan, and Hawaiian. Given the fact that we have in previous national presidents of, for example, the Association of Hawaiian Civic Clubs, a mainland council being from Utah, as well as an attorney general who's a Pacific Islander here for our state, and many other folks that we have in administrative and executive positions. We have great community visibility, and the mobilization efforts for Polynesian communities, mainly Samoan, Tongan, and Hawaiian, is quite robust here in the state of Utah, and in terms of presence and the political sphere and civic engagement, that has been something we've been working on for a very long time. One notable thing with the coalition and with this robust network is that we call it the Pacific Islander Health Coalition, but until very recently it has been very Polynesian focused at the exclusion, I guess could be the correct word, of our Micronesian and also Melanesian cousins as well. So in the next slide, you can see that we have recently this year we initiated a very concerted efforts to reach out and to integrate with our Melanesian folks here, which is a very, especially the Marshallese community that is growing very quickly here. And this is an approach that is a two-way approach, and it's been interesting because many of the here from the COFA nations have come from other states or other parts of the United States where there's not been maybe, I guess I could say, the best religion, or there has been misperceptions and tensions that have prevented, or a really large-scale integrated efforts for collaboration with other islander groups, even along mainstream state governments. And so here, the National Tongan American Society has really taken the lead in offering to the COFA communities space in the community, because we've got headquarters here, office, computers that they can use for enrollment, and they work with Take Care Utah, which is our navigator hub or connector hub here, really adapt some of the best practices that have worked really, really well in the last couple of years or enrollment periods with our Samoan and Tongan communities, and to now invite our COFA community folks to integrate into that. There are not any connectors or navigators here in the state, for example, that speak Marshallese or Yapese or any of the languages from the COFA nations. And we're now able to do that through Take Care Utah and the National Tongan American Society, and use that infrastructure that's already built and use that presence that's already there with the Samoan and with Tongan and with the Hawaiian groups to bring our nation folks on board there. And so we'll be doing that with assistance at the National Tongan American Society and the Take Care Utah offices, as well as on-site enrollment assistance at some of the COFA community hubs as well, which on the next slide, please. Some of those sites that are listed, including Release Church and the different associations that we have from the COFA communities here, and really utilizing our charter schools. We have two Pacific Islander curriculum charter schools here in Salt Lake City, both of which have full-time speaking and Pontean speaking staff members, as well as a large proportion of the students at these schools and their families that are served through these schools that we'll be using. The picture of some of the hires and the one with the delicious-looking roast pig there, it was a social media campaign that we ran, and we're now taking these materials and also adapting them for our COFA migrant communities. By those members on our Pacific Islander Health Coalition now, that they are really helping to inform us the ways that we can integrate, because it goes both ways in this. And I think that's what's kind of unique about this, is that it's an educational opportunity on the part of the established Pacific Islander groups that have been here in Utah for decades and decades to understand that there is a strength in numbers, and that by gathering stakeholders and really identifying and aligning those agendas, we can see a lot of similarities that are there. And on the part of our COFA community members as well, so here in Utah, there isn't territorialism, or there isn't a tension or a competition or a perception that there's competition for resources here in the state, that they're welcome to jump onto the infrastructure that we have established already in a way that can help build infrastructure as a newer group community as well. So those are some of the events that are some of the activities and approaches that we're using here, trying to reintegrate our COFA community members into some of the other Polynesian infrastructure and organizations that are already working on enrollment and have been doing a really good job with that, and had them inform us and using that to help us build their communities as well.
Yahweh Staho, Bree from Arkansas. Next. Next slide, please.
Yep, we've got your slides up there. We've got the map up.
Yahweh, welcome. A greeting from Northwest Arkansas. This is Grace Donahoe, and I wanted to share with you what's happening in Arkansas. And this is a map of Arkansas. In the 1970s, a fellow named John Moody came to Northwest Arkansas, and he found it a delightful place to live and work. Get the word around the Marshall Islands, and so we have now between 8,000 and 10,000 Marshall Islanders living in Northwest Arkansas, who is really a great marketer. Next, Springfield District is where my children went to school, and they've seen a huge number of Marshall Islanders attending their schools. Some of the things that they've adapted to, they have a state literacy program in 14 of the schools, which reach out to Marshallese and Hispanic parents, and they work in conjunction with the local technical school, which provides the teachers. They have many Marshall Islanders working for the district, including pictured bottom of the slide is Anita Ebon, who is full-time translator, so that all of the materials filmed to parents, Marshallese children, are in Marshallese. And then we have big celebrations with our seniors that are graduating. We're really proud of the increased number of seniors. Next, please. There is a Consul General office in Springfield, Arkansas, expressing a need to serve the many Marshall Islanders that live here. At the Consul General, Carmen Chongam. Please. We're very proud of the first Marshallese 501c3 organization founded by Melissa Leylon. She is a Marshall Islander. She's a U.S. citizen, and she's the first interpreter in the United States. They're housed in the same building as the consulate, and currently they are enrolling people in the Affordable Care Act. Please. They're at our local community college for another nonprofit called Marshallese Education Initiative. It's based in Springdale, and it's designed to cultural and historical awareness of and promotes educational opportunities for the Marshallese population. They also conduct a Marshallese oral history project, government through education project, and promoting awareness of nuclear issues and the impact of climate change on the Marshall Islands. Next, please. July 1st of this year, the Center for Pacific Island Health opened at the University of Arkansas for Medical Sciences Northwest in Fayetteville, Arkansas. It is medical, does not provide clinical services. It's focused on four things: research, community programs, training, and policy. And a co-director, Dr. Nia, is a COFA migrant. She has a lot of knowledge about health issues, practices, and so we are really delighted that that just began July 1st of this year. Please. Years ago, I founded the Gaps in Services to Marshallese Task Force. We call it GAPS. And started when I was employed. I'm retired now, and I've continued on. We have about over participants that email messages, and it's really an exciting possibility or exciting advance for us. We focus on acquiring demographics, getting a better handle on how many Marshallese live in Arkansas, on health disparities and acculturation. In 2010, we were involved in trying to promote a better collection of census data for Marshall Islanders, and you'll see we had T-shirts made and also an acculturation booklet that encouraged Marshall Islanders to complete the census form, not only identifying that they're Pacific Islander, but that they are a Marshallese. We also received some funding from the Centers for Disease Control to develop a health survey, research assessment of the health behaviors, attitudes, and beliefs of the Marshallese population. The survey is done in both English and Marshallese, and Marshall Islanders to assist with a. We're targeting 600 individuals to take the survey, and we had 1,289 respondents. We have tremendous help from the Arkansas Department of Health In-Town Health Initiative. We have a grant from the Arkansas Minority Health Commission to create a booklet entitled Living in Arkansas, What You Need to Know as a Marshallese. It's both in English and Marshallese and in print. We're working with the Arkansas Minority Health Commission. We decided that we needed to update the acculturation booklet and focus on Northwest Arkansas. The new working title, and if you'll go to the next slide, please, is Living in Northwest Arkansas, What You Need to Know as a Marshallese. What we're going to do is put this particular acculturation booklet on January 2016. We're also taking the template for this booklet and making it available to other regions in our state that have an increased Marshallese population. Next booklet is going to be twice the size of the initial acculturation booklet. We talked amongst ourselves. We realized that there were many topics that we had not covered in the initial booklet. We added information about being depressed and calling for help, a crisis line, suicide prevention, also information about money. But we've really expanded the health care section. It represents 36% of the content. And what we have tried to do is walk Marshall Islanders through an appointment at a doctor or clinic, citations as far as making the appointment, attending the appointment, and insurance for children, how for an appointment, information about community clinics, hospitals in our area, the health department, including the Joe Bates Clinic, which serves Islanders and Hispanics. Our clinic in Fayetteville, our walking clinics, the WIC sites, mental health services, hospice care sites, care resources, dental clinics, disability services, and understanding health care terms. Information, addresses, phone numbers, and if there are Marshallese working staff to assist them. Next, please. We're really proud that we have 3 resources in Northwest Arkansas for the Marshallese population. There's a newspaper, and a radio station promoting information and positive things going on within the community, and then contact information for the consulate. Next slide, please. Tyson Corporation invited all these ministers in Northwest Arkansas to come to a luncheon, a tour, a poultry plant, and then to have a forum to talk about concerns and issues that they were facing. And I'm just really proud of our area businesses and industries that are coming to the plate and networking with us to improve the local islanders in our community. And the last, please. These are some of the issues facing Marshallese in Arkansas: transportation to and from work, medical appointments and dental appointments, and our local public transit, regional transit, has partnered with George's and Tyson's and Cargill to expand services to take employees to and from work. The driver's license test is not in the Marshallese language, despite numerous attempts on our part. Migrants are not eligible for the expanded Medicare option. The insurance is too high for many, and most cannot afford the employee insurance. And then experience challenges in enrollment with the CARE Act. I thank you for allowing me to share the wonderful things happening in Northwest Arkansas and in the state, and I put it on to the next presenter.
Good afternoon. My name is Howard Ng, and I'm with the College of Public Health at the University of Arizona. And thank you for the opportunity to present our experience with the working with the Marshallese community. My presentation is divided into 4 areas. The first one is a review of the Asian Pacific population outreach challenges. The next one is a description of the 4 steps approach to outreach the Asian American and Pacific Islander communities. The next one is to describe our outreaching activities to the community. And finally, the next one is to, can we go just for a minute, please? And the last one is to share with you the lessons learned. Next, please. Many of the Asian American Pacific Islander population outreach challenges that many of you are already familiar with. And these challenges that was facing us in Pima County, which is located in the southern part of Arizona, which is close to the U.S.-Mexico border. The challenges include that the county is very large. It's larger than than New Jersey, the state of New Jersey. Communities are closed to outsiders. There are many cultural and language barriers. May not see the urgency or the need for health care coverage. Already, there's also limitation in health literacy, little or no knowledge about health insurance, awareness about health coverage availability, little or no knowledge of using the computer, and with the subsidy coverage with the health insurance marketplace, many Asian Pacific Islander families still cannot afford it, which has already been mentioned by other speakers. Slide, please. The process that we used was first to meet with the Asian American Pacific Islander community leaders to determine if there is a need for assistance to outreach to their insured. If there is, the program works very closely with leaders to come up with the most effective outreach strategies and community presentations, including giving the presentation both in English and the preferred language in the community. Then we follow up with the uninsured who indicated in the attendance sheet that they would like assistance to get health care coverage. This gives us permission to follow up with those individuals. Finally, is to provide assistance to the uninsured to obtain health care coverage. Please. I would say we use as we met with the leadership of the Marshallese community in Tucson, which is where in Pima County, there are 2 groups that are affiliated with 2 different churches. First group we met on December 20th of 2013 and determined that there was a need in terms of helping the uninsured and decided on the presentation format, the date, which was January 5th of 2014, and the would be both in English and Marshallese. On January 13th of 2014, we also met with the second group and also did the same in looking at is there a need for assistance, and the leadership indicated yes, and also decided on the presentation side, which was January 26th of 2014, and the format in terms of presentation, which would be in English. Next slide, please. This is where the presentation was held. Gave the presentation on the marketplace just before a community dinner event. Next, please. Shows that the presentation was given by our navigator, which was translated in Marshallese. On the top slide, you can see this is the pastor's son, and the bottom slide is the pastor. Both gave the translation in Marshallese. Next slide, please. Show audience in which our navigator was giving the presentation to. Next slide, please. This was given on January 26th of 2014, and this was given at the Church of the Painted Hill. Next slide, please. Next slide, please. As you can see, was given at the sanctuary in the church. Next, please. This slide is a summary of the two presentations in terms of who attended. A total of 65 attendees. 66% indicated that they did not have any type of health coverage. 77% indicated they needed health insurance. And 83% indicate they need help in enrolling in a marketplace plan, and 89% of those who attended requested us to provide additional assistance. Next slide, please. What learned? What learned was, as already mentioned by previous speakers, you need to work closely with community leaders to sustain outreach. There are cultural and language barriers, as many know, the island culture. Health literacy, little no knowledge about health insurance, and all the U.S. healthcare system. There's also lack of awareness where to get healthcare coverage. Other states, Arizona's Medicaid program are not available for Marshallese folks. Problems with documentation submission. Even with the correct documents provided, sometimes some of the uninsured will get notices saying they did not receive the appropriate documents, and it goes through several steps trying to get that taken care of. As I mentioned, even with the subsidized coverage with insurance marketplace, families still cannot afford it. And health plans exposed with very high deductibles. As resulting, many have to pay out of pocket just to get services and not afford the out-of-pocket costs, end up not using health services. And I've already mentioned community health centers are a good option for those who are not eligible for coverage or cannot afford coverage. And the step is going from coverage to care. Many still don't understand how to access or use the health services once they become covered. Next, please. I'd like to be the Laguna Marshallese Assembly of God, Pastor Sebelius, and also his son for the translation and the help, and also Church of the Painted Hills, the two Marshallese Ministry, UCC, and Carson Taka, who also helped with the presentation and helped arrange the sites. And I'm going on to the next presenter, Kathy Wishman.
Yes, good afternoon and good morning to those in the Pacific who are listening. I'm Kathy Wishman. I am the staff of the Office of Pacific Health, which so Shabir and I formed that team, and I'm part of the Region 9 office. Asked me to quickly summarize a rich amount of information, expertise, and experience that was provided by the previous speakers. Let me just note two critical things, that there are 3 Pacific nations that the U.S. has a very special relationship with, unlike as with any other country, and that Compact of Free Association and COFA citizens are able to legally travel, study, and live in the U.S. indefinitely. These citizens are also eligible to participate in the ACA marketplace, and they participate but are eligible for the premium and cost sharing subsidies. In states, they're eligible for state-funded Medicaid benefits, and in additional states, children and or pregnant women may be eligible for the federal CHIP benefits. It differs between each state. It needs to be asked within each state what is covered. And sometimes reach out to the Medicaid agency to do that. The most expedient way of getting those answers. To action. I say that throughout the speakers, they have mentioned partnering and outreach. And for many of you who may have felt that you've been working in isolation to get the word out or to get accurate information to educate communities and policymakers, we're hopeful that this webinar is a step toward doing that. When we look at going forward, I think our focus over the next several months is outreach strategies for this third enrollment and resolution of enrollment barriers. After season, as Howard just mentioned, it's recognizing that insurance is only an initial step. It's not to use the insurance to access care that will require our attention moving forward. And find those barriers and then sharing them as we did with this webinar. It's the awareness about those legislative efforts to restore access to federal aid. There are a broad range of states represented by the participants on this call. And by working with your congressional delegates, also your local legislature, such as they are doing in Oregon, I think that we can, again, move minds, marks, and perhaps get those policy changes that are so desperately needed. Bring up a special issue, and that deals with language access, and it's been noted throughout by different speakers. Many people, when they think of the ACA, think of insurance. It's also important to realize there's a section 1557 that relates to non-discrimination, and part of that addresses individuals with limited English proficiency. The Department of Health and Human Services is now in a process of, they have proposed rules for that section. Those are now, individual entities can comment on those rules, and I would encourage individuals to take particular notice of the rules related to LEP, limited English proficiency, as the rule would require of health facilities and insurers in terms of their responsibility to work with and address individuals with limited English proficiency. This is really an opportunity for all of us on the call and all those with whom we work to have a part in the policy-making process. Additional information provided here, and there will be additional information on the resource sheet. And this is really continuing with these discussions, the networking to problem solving and the sharing of best practices and materials. There were excellent materials. Grace Minutes shows many of the materials that they're using. There are materials out there that will be provided through the resource sheet. A mahalo to all our presenters who really made this webinar what it is. And the other group, well, there are two groups who I would like to ensure that we thank. This was put together by a dedicated group of HS, as well as individuals from state offices. And they're noted here, again, a special thank you for taking the time to really, and a very special thank you to Shibroto Banerjee. But I want to thank all the participants who've taken value time from their busy schedule to participate in the conference. And request, going to the next slide, you help us look at how we can perhaps move forward and write additional such webinars. You can by submitting questions that you may have, completing the survey. You can access the replay for this and continue with the collaborative discussions, networking, and problem solving. We look forward to understanding what additional things may be needed by you all to work most effectively with the COFA communities, but also with other immigrant communities. And I would just pose at this point is that I have found this type of webinar helpful. Perhaps a future webinar could actually go into the issues surrounding limited English proficiency and what the rules and regulations are to ensure that our local providers and our insurers will be meeting those. And that, I'll say and goodbye from Honolulu, and let me just turn it back to Shibroto Banerjee for a final word. Thank you.
Thank you, Kathy, and thank you again, everyone, for participating. As indicated, we will be happy to respond to questions offline through the email process. We've been documenting the questions that we've received. We'll be following up with some post-webinar emails. And so, as many of you have received many emails from me in the last couple of days, you will be receiving some more, and we look forward to continued collaboration and dialogue. Thank you very much. This concludes our webinar for today. Have a great week.
Thank you for your participation. You may now disconnect.